Okay, we're back. At this point, I want to talk about some of the potential red flags that could alert us that there is a need to place a patient in restraints. Because sometimes making that decision can be rather difficult. And I'm not going to say that I'm going to clear this up to the point where you always know the right decision to make here. But I want to give you a few tips to maybe make it just a little bit easier on you. So the important thing here is to know your patient and look for certain signals that this could end up being a bad situation if they're not placed in restraints. So this is a real call. It was a routine transfer to a behavioral unit that was about 3 hours away from the sending facility. The nurse reported that the patient had trouble with women and actually sexually assaulted. Yeah. No restraints were used despite all of this. And en route, the patient became what the paramedic said was psychotic. He punched the paramedic in the face, then bit down on his finger. Well, the paramedic, feeling like he had no other alternative, he freed his hand by punching the patient in the face. Law enforcement arrives, and the patient's given Versed, 4-point restraints, and a spit hood. Now, the last line of this incident report, this is exactly what it said. The remainder of transport was uneventful. Thank God, right? I mean, good grief. Could this have been any more eventful? So, the situational awareness, this is the thing that we're talking about. It's very easy to miss what you're not looking for. So let me give you some things to watch for. First off, there is a greater incidence for violence when these particular traits, any of them, are present in your patient. Now, this is not to say that every patient who presents with this is going to assault you. It just means that of the patients who might assault you, majority of them have one or more of these things going on. So you need to have a higher index of suspicion, be on the alert anytime you have a patient with this. For starters, intoxication is really the biggest one. When a patient is intoxicated, whether that's drunk or drugged or both, there is a greater risk for violence to occur on the scene. Another one is psychosis. Now, I'm not talking about just a psychiatric diagnosis, not that they're schizophrenic or that they have bipolar or some other issue, borderline personality disorder. Psychosis means they are out of touch with reality. So this would be someone who is experiencing delusions or hallucinations. You know, they're seeing things, hearing things, or believing things that are not true, that are not grounded in reality. And then another thing is bizarre behavior. Very closely related to the psychosis, but think of the guy that we saw in the video earlier who had been dancing naked on top of a tractor and then wouldn't speak and just was behaving bizarrely on the scene. Okay. Another one, I read a report that talked about a patient who was inside a Denny's restaurant, walking from window to window, smashing his face through the window. That's a little bizarre, I think we'd all agree. Altered level of consciousness. This would be postictal patients after a seizure. Believe it or not, some of them can become quite violent, even if that's not their normal disposition. Hypoglycemic patients, same thing. Traumatic brain injury also. And then suicidal. Anyone who is admittedly suicidal and does not want to go to the hospital with you, obviously there is an increased risk. Now, I put psych patient in here with the note, they must have other traits. Again, it's not that they are a psych patient, it's that some of these other traits like intoxication, psychosis, suicidal, one of the, or more of those goes along with the person who has a psychiatric history. Involuntary patients in general, anyone who does not want to go to the hospital, who's being forced to go to the hospital, well, obviously there's a greater risk of some violence breaking out. If the patient on scene presents with threatening body language, tone of voice, etc., the majority of communication is in fact nonverbal. It's not what you say, it's how you say it. So those things we have to consider. Those are there, and we are designed to read those behaviors for a reason. So what do all these traits have in common? Unpredictable, irrational behavior. Patients with these traits, they are unpredictable. You cannot anticipate what they're going to do. They're not grounded in reality. They're not rational. You can't reason with them. If you have any of these things present, you have to consider the possibility that they are going to act rashly and not the way a normal, rational thinking human being would act. So there's greater risk. But there's another side to this list. A person who has a known criminal history or a history of becoming violent in similar circumstances. So, for example, if you respond to a residence where a patient has taken some sort of substance, and when you arrive, the wife tells you that her husband, the patient, last time he took this drug, he became incredibly violent and beat the snot out of their neighbor. He's taken that drug again. Now, even though he's not been violent yet, could we use his history of becoming violent in similar circumstances as justification to transport him in restraints? The answer is absolutely yes. And we'll talk more about that in just a second here. But other things, aggression that was displayed prior to your arrival. Maybe they fought with a police officer. Maybe the call was an assault. If they are found in custody or handcuffed when you arrive on scene. Now, this one would apply for paramedics, EMTs who transport someone from one hospital to another. Where the patient had to be restrained, sedated, or secluded in the ER prior to the transport. It's not uncommon for this to be the case where you show up to the ER to pick up the patient for the transfer, and the nurse says, oh, yeah, we had to put him in restraints. We had to sedate him and stuff. Yesterday when he came in, he had been really violent and we had to give him some Haldol. But, after receiving that Haldol 14 hours ago, he's been perfectly fine and he's not giving me any trouble since I came on shift 3 minutes ago. So you shouldn't have to put him in restraints. Yeah, you hear anything like that, put this dude in restraints. Okay, it's relevant, recent history where those things were needed, and you absolutely can use that as justification today. If they assaulted or attempt to assault you or another member of the crew prior to transport, that's a pretty good indication they might do it in transit. So what do all of these traits have in common? Relevant history or a behavioral pattern. And the reason why you can use these things is because the best predictor of future behavior is relevant past behavior. So if you are told one of these things or you become aware of one of these things that happened earlier, just make sure you document very well who told you whatever, who said what, and the other information that was given to you, and make sure you document it very clearly anytime you take someone against their will with one of these things as justification for doing so or putting them in restraints. Now, I realize very, very well that there are gray areas to be considered here. Sometimes you don't have someone who falls neatly into any of those categories, but you're looking at the situation going, ah, man, I don't know if I've got a justification to put him in restraints, but man, I'm just getting a weird vibe off this guy. If something like that occurs, there are some things that thankfully in our district, we have some options for middle ground. One of which is this device right here, the seatbelt locks. Now, I want to stress that this is minimum level security. Can these be beaten? Yes, they can. I have experimented with it and beaten it myself multiple times. However, Someone who's not familiar with it, this will, at minimum, slow them down if they are trying to get off the stretcher during transport. So this does not appear as as aggressive or it's not as extreme in appearance as putting a patient in 4-point restraints or administering something like ketamine. So this is a good middle of the road minimum security thing that you can put into place. At least it would slow them down long enough to buy you a moment in time if they start to try and get off the stretcher and become violent. And I want to reiterate, this is a thing that you'll find on the ambulances now. These limb holders, these little plastic devices. I want to stress that these are not a restraint device. If you didn't know this already, these things, if a person wants out of them, it takes a split second to get out of them. They are not strong. So never use this as a restraint on a patient. It's really intended to be used just for keeping a patient's hands together if they are unresponsive and you're wheeling them out or carrying them out of a room or whatever, and you're trying to keep their arms from flopping around and getting in the way of the door and so forth. That's all it's for. So remember one other thing. Biggest lesson to take away from this. Your safety comes first. And I don't say that flippantly. This is the solid, unequivocal, undeniable truth. The moment the scene becomes unsafe, your duty to that patient ends. Get away from the danger. So I told you at the beginning that we were going to talk a little bit about ketamine. So we're going to touch on this specifically. We're not going to talk a lot about the pharmacology of it all or that sort of thing. And you don't even have to come away from this knowing the dosages. When you see numbers about dosages, it's just used as a comparison to look at one dose versus another. Is one higher or lower than the other, and just to see things in context. But this is not about drug calculations today. So if pharmacology is outside your scope, don't worry about it. That's not where we're going with this. This is really basic level stuff that anyone, even lay people, can appreciate. So ketamine for acute agitation. What you're looking at here is what has been referred to as the ketamine continuum. There are different dosage ranges based on what effect you're looking to have in the patient. For example, ketamine can be used just for pain relief, analgesia, and it's a relatively low dose, as you can see there. A little bit higher dose, and you reach the point of partial dissociation. And then you get up to where you give them so much that it is full dissociation. This is the point where you're basically giving the patient general anesthesia, and you could perform surgery on them at this point. Okay, that's a really high dosage there. So when we're treating patients with acute agitation and we're just trying to chemically sedate and restrain them, this is the sweet spot right here. About 1 to 2 milligrams per kilogram IV, or 2 to 4 milligrams per kilogram if it's given in the muscle. So keep that in mind where that falls on this continuum as we talk about these cases. So in recent years, ketamine has come under fire, specifically EMS use of the drug. And it's called into question where there are authorities and protesters and all sorts of other people in the political realm who have been calling for the removal of ketamine from EMS and fire services. It's gone that far, and it's actually breached into claims of racism and other things, which may or may not be part of the equation. I don't know, but the fact remains that some ketamine-related disasters have occurred, and it has caused some outrage, and there have been a lot of implications for us because of that. So we're going to examine a couple of these cases and answer the question, what went wrong? How did all of this happen? And what can we do to avoid ending up in similar situations? So this is kind of an awareness thing for you. First off, I want to make very clear that when I relay these stories to you, it is not meant to ridicule the people who were involved in these cases, the EMTs, paramedics, firefighters, law enforcement. That's not the case. The point here is just to learn from the lessons that came out of these disasters. The first is related to a man by the name of Elijah McClain. This is perhaps the most highly publicized of all these tragedies. And Elijah was 23 years old at the time. This happened back in 2019 in Colorado, and he weighed about 143 pounds. So he was a really, really little guy. Let's take a look at this video, and then we'll discuss what we see.
This is surveillance video of Elijah McClain's final trip to buy iced tea at a convenience store in Aurora, Colorado last August. His family says he sometimes wore a ski mask to keep warm because he was anemic.
After paying for his items, he turns around and bows to the man behind him in line. His family told NBC News this was his signature gratitude bow. At 10:30 p.m., a man calls 911.
Yeah, he's walking south on Billings Street and he has a mask on.
The caller tells the dispatcher a man looks sketchy, but makes no mention of any crime.
Were any weapons involved or mentioned?
No.
Officers arrive at the scene.
Stop. I have a right to stop you because you're being suspicious.
Well, okay.
Turn around.
And within 19 seconds, an escalation.
Let go of me. No, I am an introvert. Please respect the boundaries that I am speaking.
Stop tensing up.
Stop.
Relax.
Stop. I'm going home.
Relax, or I'm going to have to change this situation.
All three officers wrestle McClain to the ground.
Give us more. Give us some more units. We're fighting them.
At this moment, one of the officers uses a carotid control hold on McClain, a tactic that involves an officer placing his arm around a subject's neck, applying pressure, and restricting blood to the brain via the carotid arteries. Responding officers later told an Aurora police investigator that McClain briefly went unconscious and the officers released the hold. At 10:46 p.m., just over 2 minutes after the first officer made contact with him, McClain is pinned to the ground and says this.
On the ground. It's Elijah McClain.
We had to use carotid.
That's what I was doing. I was just going home. I'm an introvert and I'm different.
He come out? He's out? Was he out?
Yeah.
I heard some snoring.
He wasn't completely.
He didn't lose consciousness? Yeah.
I'm just different.
I'm just different.
That's all. That's all I was doing.
It was actually Rosenblatt.
I'm so sorry.
You're going, dude.
I have no gun.
That's where I tried carotid.
I don't do that stuff. I don't do any fighting.
Other units that are not here,
Why
they can slow it down a little bit.
At 10:49 p.m., McClain throws up a first time.
Stop.
Oh yeah, I'm sorry. I wasn't trying to do that. I think I can't breathe correctly because.
Over the next 4 minutes, McClain gets sick a few more times. Officers are also heard multiple times asking him to stop fighting.
Rolling this way, dude? Yeah. Are you able to?
My legs locking up.
There you go. Just like that.
You're good.
Don't
You're
get
good.
up, dude. It's not going to be good for you. I'm telling you right now.
If you keep messing around, I'm going to bring my dog out. He's going to dog bite you. You understand me?
At 10:54 p.m., McClain is still on the ground, and an officer says this.
So when the ambulance gets here, we're going to go ahead and give him some ketamine. Yeah, sounds good. Perfect. Let's give that a couple of minutes and then we'll put him on.
Whatever he's on, he has incredible strength.
Yeah, crazy strength.
10:59 p.m. A paramedic administers 500 milligrams of ketamine to McClain in an attempt to sedate him.
7 minutes later, responding officers are told he has no pulse in the back of an ambulance.
Are you serious? Yeah.
He's revived, but is brain dead and is taken off life support 3 days later.
The coroner concluded last November that a combination of physical exertion and a narrow left coronary artery contributed to McClain's death, but could not determine the cause of his death. He added that it could have been either an accidental death caused by a reaction to the ketamine, a natural death, or a death linked to the carotid control hold used by officers.
McLean was a 23-year-old massage therapist who liked to play the violin for shelter animals. He weighed just 140 pounds.
Well, there you go. No matter how you slice it, this was a tragedy and arguably preventable. Now, I want to stress that it's unclear as to whether or not ketamine was the primary cause or even a contributing factor in McLean's death. The coroner could not rule it out, and an independent physician said that she found no definitive evidence that the drug led to McLean's death. Even before paramedics administered the ketamine, McLean had already vomited and lost consciousness after the police subdued him with a carotid hold. So was it the chokehold and subsequent hypoxia that did him in? Was it restraint asphyxia from being basically dogpiled face down on the ground for so long? Was it the ketamine? A combination of all of those things? We honestly don't know. We probably never will. Even to this day, there are experts debating whether or not ketamine contributed to it. Regardless, what we do know is that McLean received an incredibly high dose of ketamine that he never should have received. So let me show you this to put it in visual perspective. So 143-pound Elijah McLean received 500 milligrams of ketamine. That's a lot. And look at where we said the dose for acute agitation is supposed to be, right around there. This is where Elijah McLean's dose fell. At his weight, he received a dose more than 7.5 milligrams per kilogram, which puts him into the realm of general anesthesia. I'd like to call this an isolated incident, but unfortunately, within the very same week as the Elijah McLean tragedy, there was another man, also with the first name Elijah, also in Colorado, who almost suffered a very similar fate.
How much he had to drink?
I'm good.
Elijah McKnight says what happened to him during this 2019 arrest outside Aurora, Colorado, should never happen to anyone again.
I was out cold for 3 days on life support, pretty much.
McKnight admits he was drunk on the sidewalk when police arrived to check on him. He tells police there are warrants out for his arrest. All is calm until an officer attempts to cuff him. He resists and is cuffed and tased. Oh! But he says what happened when paramedics showed up nearly killed him.
They were acting like I was just the Incredible Hulk and that I was tossing them around.
You're a little too hyped up right now. You gotta relax, you guys. A little bit.
I am being quiet.
You are. I appreciate it, man.
Paramedics initially determined he doesn't need to be hospitalized.
He doesn't need to go to hospital.
Let me know.
It's up to you guys.
But then a police officer asks this.
You guys can't give him anything, can you, unless he goes?
We can give him ketamine and he'll be sleeping like a baby, but we'll have to take him to the hospital.
Don't inject anything in the mother hand. Oh, yeah.
Just gonna be a fight the whole way.
No, I was still.
We're going to the hospital.
I mean, he's fucking the three of us. Just give it to him.
CNN reports that they first gave him a 500 milligram shot, then a second 250 milligram shot, which is definitely over the recommended dosage by the manufacturer and just by doctors.
This is the first of 2 ketamine injections paramedics administered to a very drunk Elijah McKnight last August. Later, he ended up here, intubated in the intensive care unit for several days.
How you feeling now, Elijah?
Ketamine is a drug Colorado paramedics can only administer under a state waiver. And according to state guidelines, it should only be used on patients who are so combative someone's safety is at risk, or to calm extremely agitated patients who experience a condition called excited delirium.
Rescue's here to talk to you. Are you going to cooperate with them?
Paramedics reported McKnight was uncontrollably combative and appeared to be in excited delirium when they arrived.
Wow. Okay. I don't know how much education everybody's had on excited delirium or how many videos you might have seen in the past on this. I can tell you without any shadow of a doubt, Elijah McClain was not experiencing excited delirium, nowhere even close. So this was another one that hit the headlines and led to a lot of controversy. But first, let's look at the dose that Elijah McKnight received. He weighed about 210 pounds, and he was given the full 500 milligrams, then an additional dose of 250 milligrams only minutes later, for a total of 750 milligrams of ketamine. So once again, here's where acute agitation dosage is supposed to fall on this continuum. And here is what Elijah McKnight actually received. Almost 8 milligrams per kilogram. So again, about double what he should have received, and enough to qualify as general anesthesia. Wow. And in the body camera footage, a sheriff's deputy can be heard asking the medical crew, "Can you guys give him anything?" And the paramedic says, "We can give him ketamine and he'll be sleeping like a baby." All right. How does that kind of thing look on the 10 o'clock news? Not very good. And a lot of this body cam footage, you got to be real careful what you say out there, even if you're just being flippant and not really serious about what you say, because you have to always consider that you're being recorded. You probably are in this day and age. And things can be interpreted or misinterpreted in a way that does not look favorable upon you. So you have to be very careful about these things. So the snowball effect, just like a snowball rolling downhill, the PR nightmare just keeps growing bigger and bigger. But it's not limited to the state of Colorado. Many other states are facing similar problems, including Minnesota and South Carolina. And it's not just a matter of dosage errors. That's only a small part of the problem. There was an article in the Star Tribune that really drove home the point that our words alone can have a dramatic impact on how our actions are perceived by the media and the general public. Look at some of these words that were included in this article in the Star Tribune, and ask yourself, was this a win or a loss in the court of public opinion and in the eyes of the media? These are some of the things that were caught by this report. They made the statement in the article. They gave chemical restraint to a patient who was already in physical restraints. Now, that fact alone is not problematic if you know the medical reasons for doing this. I am a firm believer that if you use physical restraint, you should use chemical along with it for a variety of reasons, not least of which is that if a patient is in excited delirium and they continue fighting against the physical restraints that are on them, their metabolic acidosis increases, their condition worsens, they're hyperthermic, and eventually they run the risk of going into sudden cardiac arrest. Ketamine in that situation can be life-saving by calming them down so they're not expending so much energy and burning up so much muscle tissue. So anyway, but the public doesn't know that. What they saw was someone getting sedated who was already restrained. Why would you give him a drug if he's already restrained? He's no longer dangerous. That's how the public will look at something like that. The article referred to ketamine as a recreational hallucinogenic drug referred to as Special K. So now we've got a recreational drug that paramedics are giving patients. And in one of the body cam footage pieces, there is a paramedic who makes the statement, the patient just hit the K-hole. He used the expression K-hole. Again, a very flippant comment, just maybe trying to be funny and alleviate tension on the scene or whatever. But it looked punitive, and it looked like he was mocking the patient on the video. So another thing was they mentioned that the police policy manual listed ketamine as a potential date rape drug. So that got mentioned in this article. And then, of course, the medic caught on camera telling a police officer he'll be sleeping like a baby. All of this paints a very, very nasty picture. So, and then perception's reality. Regardless of whether it's true or imagined, this is what happens when we lose in the court of public opinion. You have to assume everything you do and say is being recorded because it very well might be. So, spiraling out of control, we had sensationalism, heightened security, things taken out of context and blown way out of proportion. And this is simply what happens when we're not careful about what we do in the eyes of the public.
I think this story is very relevant right now because this story actually involves a black man and some white police officers and paramedics and medical professionals. Some people didn't want to talk to me about this and protocol and what's going on.
And the Fox 31 problem solver is asking important questions for you about the use of ketamine by paramedics.
In the body camera footage, you hear him shouting at various times, internal affairs, don't kill me, don't break my legs, things like that.
I tell you what shouldn't have happened. They shouldn't have injected me with ketamine.
When we see things that don't add up, we're on it. We want to go ask the authorities, we want to go look at the video, we want to compare these things, we want to bring these situations to light so that change can possibly happen, or at least some sort of discussion to make things better. Our role as journalists is important to ask the questions to make sure everybody is safe.
Thank God the media is here to protect us. And that brings us to another huge source of ketamine's public relations crisis, and that involves our interactions with our brothers and sisters in law enforcement. These requests by law enforcement asking paramedics to give a patient ketamine, that also looks terrible. What in the world is a police officer doing asking a medical professional? What are they doing asking that medical person to give a drug to someone? The police officer is not certified as a paramedic. They don't have any medical background. It's inappropriate. And likewise, it does not appear very well in the eyes of the public. So this not only happens in Colorado, but in Minneapolis. This was getting a lot of national attention. And like I said, it's other states as well. South Carolina, in the last couple of years, passed a law that said a law enforcement officer cannot direct a paramedic to give ketamine, cannot even suggest it. And no one can administer ketamine to a criminal suspect simply because they're a criminal and you want to sedate him. It has to be an actual demonstrated medical reason. So, and then they've got a penalty here of imprisonment of up to 3 years for this violation. And Colorado, not all that long ago, just recent, last year, I think, signed a bill into law that limits police influence on the use of ketamine. So it prohibits the officer from using, directing, or unduly influencing the use of ketamine. Same as what South Carolina did, essentially. And it outlines conditions that have to be met before EMS can even consider administering ketamine to a person. And I'll just say, without going to all the weeds here, the conditions that are mentioned in this law are very common sense. We have them in our own policies here and procedures. But some things that were in the initial draft of this bill were unbelievable. Like, one of the things that it required initially was that the paramedics weigh the patient prior to giving them ketamine. Excuse me, sir, would you mind not freaking out for just a second, just long enough to step on this scale so we can figure out how much drug to give you? Yeah, that's not going to work. Now, thankfully, the opposing view of this, the other people on the other side, worked with lawmakers to get this changed so that now it says you have the option of weighing the person, or there have to be at least 2 personnel trained in this sort of thing in EMS, and they have to agree upon a weight, an estimated weight for the patient, which is not bad. That's actually a pretty good safety measure. But yeah, if it had been left for patients to have to be physically weighed, it would have effectively killed the use of ketamine in Colorado. Now, before we move on, I want to give you a quick update on the Elijah McClain case because it is still ongoing. A civil suit recently ended with a settlement between the city of Aurora, Colorado, and the McClain family, but the story's far from over. In just recent months, the officers and paramedics were charged criminally negligent homicide and manslaughter. This is what they've been indicted for, and the case is ongoing. But if this ends up being a successful lawsuit and criminal charges against the paramedics and officers, if they're found guilty, that's going to be really quite unprecedented under these circumstances. And if they are found guilty, it will have long-lasting effects on the use of ketamine by EMS services nationwide. It's kind of a scary possibility. We'll just have to wait and see how it all plays out. But anyway, that's why we need to be very careful to know what we need to do to protect ourselves as well as the patients. We have to keep that in mind as well, obviously. That's our whole point, our whole mission. So let's talk about what went wrong in these cases. What were the underlying factors in the present ketamine controversies? Well, first, the big one is obvious: dosage errors. Another thing that I think went wrong here involves role confusion, meaning the point where EMS and law enforcement were crossing over their responsibilities and doing things that weren't actually in their specific purview, their scope, so to speak. You had law enforcement officers giving recommendations on drugs and drug dosages. You had paramedics who were using these drugs to basically incapacitate criminal suspects for no other reason than to control a criminal, not to sedate someone who is experiencing excited delirium or has a psychiatric condition or whatever. So there's been some role confusion there. And then another big one, probably the biggest one, is public perception. So here are the lessons that we can learn from this to protect ourselves and our patients. 1, use care when estimating body weight and calculating any drug doses. And then 2, one of the things that should be considered is services using lower doses. We actually started using a lower dose here at SCAD. That's in our new clinical guidelines. And there are other tools that can be used. One's called the Richmond Agitation Sedation Scale, which is basically a rating scale where you look at the patient and judge their level of agitation or sedation, and it gives you a numeric value, and it gives you a target. So we have in our guidelines the rule to not sedate someone so much that they fall below a score of -2. It doesn't really matter that you don't, if you don't know what this refers to or how the tool is used, but the point is we've got an objective way, a more objective way to assess a patient's level of sedation and make sure we're not over sedating them. Another important point is to get the patient off the ground and either supine or semi-Fowlers very quick. So if they're given ketamine, don't leave them on the ground, don't leave them dogpiled. As soon as they are sedated enough, get them on the stretcher and out of that prone position. Vital signs need to be assessed immediately after administering ketamine. That was one of the things that was not conducted appropriately in the Elijah McClain case. No vitals were assessed. Heck, the paramedics didn't even perform an assessment prior to administering ketamine. They just operated off of what the police officers told them. That was one of their most huge mistakes. And then reassess frequently, at least every 5 minutes. They should be assessing vital signs and so forth, making sure the patient's breathing adequately. And again, for those of you who are ALS, you need to understand that anytime a person is given ketamine, you need to be prepared for the possibility that they are going to need advanced airways. intubation or at least an eye gel. It's not common for ketamine to actually cause someone to like stop breathing or have a breathing respiratory arrest or something of that nature. But there are cases where a patient given ketamine might have what's called a laryngospasm, where basically their airway spasms up and closes off so that they are effectively unable to get air. That doesn't happen often, but it does happen. So you always have to be prepared for the worst case scenario anytime you give ketamine. And another thing that I think we need to do a better job of is training with law enforcement, making sure everybody knows their roles, what they're responsible for and what they are not responsible for when it comes to a patient restraint situation. And then lastly, and this one's common sense, but honestly, I think it's probably the thing that gets overlooked the most and leads to the biggest problems for us. And that is, you need to always watch your attitude and be aware of how your words and actions may be interpreted. Honestly, I think that that is probably the biggest contributor to why all of these lawsuits and media sensationalism has occurred. It's not necessarily the dosage, which is terrible. But I think that the reason it's gained so much traction and so much national attention is because people were not being aware of how their words and actions would be interpreted. So just a little bit of advice there to keep you out of court and out of jail. Don't forget to complete the course evaluation and the short quiz. It's only like a 4-item quiz. And turn in that CEU sign-in sheet to Becky Price so we make sure and get your credits for being here today. Thank you so much for attending, and I appreciate your time. Wish you the best. Have a happy Friday the 13th, and be safe this weekend. Take care.